Let me thank Mr. Schweikert, the chair, and I thank all of our witnesses for staying and hanging out here for this extended hearing. My name is Gwen Moore. I'm from Milwaukee, Wisconsin, and I'm going to share with you that 64% of my constituency is enrolled in Medicare Advantage. Is much higher than the numbers that you've heard here today. People have talked about the national average being 51, 52%. And so that has caused me to wonder about the appeal of Medicare Advantage to communities and constituencies like mine and the demographics that are involved in it. I guess maybe I'll ask you, Ms. Maroney. I had a great colleague named Maloney, so forgive me, Maroney. You say that you only deal with prior authorizations being denied in about 2% of the cases. How then can your plan afford really to provide people with the level of services and care when you, in fact, get all of your care needs authorized, and how do you do that? I was curious.
Thank you for asking that question, and congratulations on the high percentage in your district. You know, our organization believes in a high-touch, proactive approach to care, and so we try to get in front of a prior auth in advance of that care. So high-touch through clinicians that are complementing the private network specifically, so that we make sure that people are getting access to their drugs, they're getting access to their specialists, they're getting access to their primary care, and we also have care navigators that navigate to make sure that the administrative burden is out of the way. If we're doing that, then we're eliminating the prior auth process without them asking for it. We're just setting it up for them in advance.
That's very good. I appreciate that. Let me ask you, Dr. Fiedler, we've heard a lot about how upcoding, coding intensity, and favorable selection really hikes up the cost of Medicare Advantage. How can you upcode and at the same time choose someone who has less health problems and have that sort of jive?
So I think there are two, so you can take any given person, no matter what health conditions they have, and what the MA plans have gotten very good at is finding an additional diagnosis that wouldn't, even if they're fairly healthy, that wouldn't otherwise have gotten recorded, and make sure that gets written down. Why is there favorable selection? I think what's also happening is, you know, frankly, in traditional Medicare, you have a broad network, fairly lightly managed plan. On the MA side, you have networks, often fairly narrow, and you have substantial utilization restrictions. And so if you're someone who needs a lot of health care and you're choosing between those two options, often the traditional Medicare option is going to look more appealing because you think it's going to be easier to get the care you need.
All right, thank you. I am concerned, and you know, maybe Dr. Fiedler and maybe Ms. Maroney, you might want to explain to me that it seems to be that there are more people of color, brown people, Latinos, African Americans subscribed in Medicare Advantage, and they don't, we've heard here today, people don't necessarily get the services that they're purported to deliver through Medicare Advantage. So it makes me wonder if people aren't being taken advantage of when they, on the basis of this demographic. So when we start talking about transparency, one of the things that concerns me is I think that former President Biden tried to get a handle on this, and of course President Trump really stopped the practice of trying to determine. Do you all think that it would help us with regard to figuring out how to reform Medicare Advantage if we knew whether or not these demographics were a part of that mix, Dr. Fiedler?
So I think it's absolutely the case that better data on Medicare Advantage would allow us to have a better picture of how the program's working overall and how it's working for particular communities. I think there are, frankly, major gaps in the data that CMS is collecting, and then to some degree the data that CMS is releasing on the Medicare Advantage program that will allow us to have a much more complete and accurate picture.
And just very briefly, you know, Medicare Advantage is, of course, pays much higher than Medicare, Medicaid, even private insurance. It's nearly double the individual market Medicare Advantage. How would the loss of $1 trillion in Medicaid, you know, the Affordable Care Act not renewing the premiums for people, how will will MA be held harmless? And the half trillion dollars triggered in Medicare cuts.
Okay, Ms. Moore, and
Okay,
your question.
I'll just let you answer, Dr. Fiedler, and then I thank the chair for his indulgence.
So if the sequester were to go into effect, that would have significant consequences both on the traditional side, traditional Medicare side of the program, and on the Medicare Advantage program.
Thank you, Ms. Moore.
I yield back. There's never enough time, but
No,
I appreciate you all. Thank you.